This is Matthew McCoyd, and we're going to go through the final section on neurology for the internist, covering topics for the board examination as outlined by your academy. So these lectures are going to cover the mononeuropathies, disorders of neuromuscular transmission, myopathic disorders, and then miscellaneous disorders or dizziness. In terms of the mononeuropathies, a 53-year-old carpenter presents for persistent pain in his right thumb, second and third digits. The pain frequently awakens him from sleep and he has to shake his hand out. He has decreased sensation over the palmar surface of the thumb and index and long fingers of the right hand, and atrophy of the thenar muscle mass. Compression of which of the following nerves is most likely? The median nerve, the ulnar nerve, radial nerve, the anterior interosseous nerve, or the medial antebrachial nerve. One thing I would tell you in these tests is don't outthink the test question. Patients with simple carpal tunnel have simple carpal tunnel. So the answer here is median nerve. Patient has symptoms highly consistent with carpal tunnel. Numbness and tingling of these three fingers, has to wake up at night and shake his hand out, is highly consistent with carpal tunnel. The ulnar nerve would be expected to cause symptoms of the fourth and fifth digit, oftentimes leading to an ulnar claw. The radial nerve leads to numbness of the back of the hand with a wrist drop. The anterior interosseous is a branch of the median nerve, but it doesn't go through the carpal tunnel. It doesn't cause sensory symptoms. Patients will have difficulty with the OK sign. The medial antebrachial is a sensory branch of the ulnar nerve, which supplies sensation to the medial aspect of the forearm. It wouldn't be associated with motor weakness or sensory symptoms in the distribution described. These are the common mononeuropathies that you would be expected to know. So there are several mononeuropathies that would be commonly asked on any test at any level of medical education. Median nerve or carpal tunnel, patients are going to typically present with symptoms of these three fingers. They'll typically wake up at night and have to shake their hand out. There may be muscle loss in the thenar eminence. They may find that certain activities worsen their symptoms. In my experience, so everyone thinks typing causes carpal tunnel, it's typically folks who do a lot of work with their hands. Electricians, carpenters, plumbers, most commonly have carpal tunnel on EMGs. Ulnar neuropathy, most typically is going to be compression at the wrist, leading to numbness and tingling of the fourth and fifth digits. Patients will sometimes have atrophy of the back part of the hand or the first dorsal interossei, and they may develop an ulnar claw or benediction sign from weakness of the fourth and fifth digit. The radial nerve, the classic test question is an alcoholic who falls asleep with his arm over a bench. The back of the arm gets compressed where the radial nerve is, and that leads to a wrist drop. Typically, there will be some strong story of compression of the back part of the arm, compressing the spiral groove, leading to that wrist drop. The perineal nerve supplies the foot. It is anatomically disadvantaged because it wraps right around the side of the knee, so it can be easily compressed just below the knee. Compression of the perineal nerve will lead to numbness of the foreleg. The lower part of the leg will become numb in its lateral aspect and lead to a foot drop. The last one to be aware of is lateral femoral cutaneous neuropathy or meralgia paresthetica. It is from compression of a small nerve, the lateral femoral cutaneous, typically right along the thigh or the hip. Patients who have had significant weight gain or weight loss or wearing tight-fitting clothing or belts or work tools, the nerve gets compressed and they develop a numb patch in the lateral aspect of the thigh. There's no motor symptoms. Patient will report numbness, usually in an oval, right along the side of the thigh. It's oftentimes a clinical diagnosis of meralgia paresthetica, numbness of that lateral aspect of the thigh. Those are the common entrapment neuropathies that are commonly asked and are at typically every level of medical education. Moving on from the neuropathies to disorders of neuromuscular transmission, we said there are three types of peripheral nerve disorders. There's nerve injuries, neuromuscular junction, and muscle. For disorders of neuromuscular transmission, a 23-year-old woman presents for a 3-month history of intermittent drooping of her right eyelid. Symptoms occur usually in the evening or when driving in bright sunshine. She has occasional difficulty chewing and swallowing. She's had 2 episodes of double vision that occurred in the evening and resolved by the following morning. Examination shows no abnormalities except for slight ptosis on the right. Which of the following is the most likely diagnosis? A diabetic third nerve palsy, Horner syndrome, myasthenia gravis, myotonic dystrophy, or a Lambert-Eaton myasthenic syndrome. This patient has fluctuating ptosis and double vision, occurring typically later in the day, and that should strongly bring up suspicion for myasthenia gravis. Fatigual weakness and double vision, along with ptosis, are highly consistent with myasthenia. In my experience, almost all myasthenics will report some visual dysfunction. A diabetic third nerve palsy can lead to oftentimes severe unilateral ptosis and potentially double vision, but wouldn't be expected to be intermittent and fluctuating in nature. Horner syndrome can also lead to mild ptosis, but should not cause double vision and usually doesn't fluctuate. Myotonic dystrophy is a common muscular disorder that can lead to bilateral non-fluctuating ptosis, but again, symptoms wouldn't come and go throughout the day. Lambert-Eaton is also a myasthenic disorder. It affects the presynaptic nerve transmission, but is usually associated with proximal limb weakness that improves with activity, doesn't get worse, and doesn't affect the eyes as commonly as myasthenia gravis does. Who to expect for myasthenia? So any patient reporting fluctuating weakness, particularly double vision and ptosis being the most common presenting features. There's a bimodal distribution. Oftentimes we see it in younger women, as well as men over the age of 65. In terms of the diagnosis, based on clinical suspicion, blood studies can be ordered for antibodies. The most commonly described antibodies for myasthenia are the acetylcholine receptor antibodies. The second most common group are muscle-specific or MuSK myasthenia. There are some additional antibodies described, but the acetylcholine receptor antibodies are the most commonly described. Also for diagnosis, an EMG can be considered. The patients get weaker, which is what the EMG shows, and evidence of something called electrical decrement, where the signals get smaller over time. In terms of treatment, once the patient is confirmed to have myasthenia, or if they're strongly suspected, imaging of the chest should be done to look for evidence of a thymoma. If a thymoma is present, the recommendation is for it to be surgically removed. Pyridostigmine or mestinon can be used symptomatically, typically lasts for about 4 to 6 hours. And this is the perfect model of autoimmunity, so immunosuppression is oftentimes recommended. There's no specific recommendation on type, mycophenolate mofetil or azathioprine, just that immunosuppression can be considered for patients with myasthenia.